And apart from that, the clinical record review or the retrospective chart review will also help in answering certain queries with regards to whether an appropriate intervention has been carried out or not. And in case an organization has a clinical protocol set in place for a certain disease condition, retrospective checking of the medical records helps us to identify if we have gone by the particular protocol, have we adhered to the particular standards that have been set in the organization. So that is just a basic understanding in terms of what a retrospective chart review is about. As you all know, the retrospective chart review will cover checking on various aspects with regards to the case sheet or a medical chart. So what are the various components of a medical charts? A very common thing, all of us would have gone through the various records during our audits, during our clinical practice, during our posting for a certain data collection, or it could be for a quality improvement project that you're looking at. So all of us would have come across the medical charts within the hospital. So basically, the information that is gathered inside the medical chart, patients' demographic details in terms of their gender, in terms of their payable capacity, because there are hospitals which reveal whether they are cash patients or insurance patients or they are government authorized, PPA patients. All those are details which are captured in a medical records. Apart from that, the medical visit details, the number of times a patient has actually visited the hospital is also being captured in a medical record. And the developmental details, the reason why I have just added it on here is if there are hospitals which are specific to, say, pediatrics care or neonatal care, the growth and development is one aspect that the people will be interested to know. And so one important aspect of a medical chart that we can look into is the developmental details with regards to it. And apart from that, the current and the past medication details is something that is an important component of a medical chart. The medical history, of course, will include details in terms of what are the disease conditions that a particular patient has had, and also the past surgical or the procedure history that one has undergone. The social history is something that I have just included here because in cases where somebody has probably opting for a transplant cases or a certain lifestyle related disease condition treatment in a hospital, the social history is something that will also be documented as part of your medical charts. Of course, immunization, even more after the COVID-19, we are all more curious to know about the immunization status of a patient. So this is an important component that we look for in our medical charts. There are other important components of medical records apart from the top things that I have listed in the previous slide. Basically, the chief complaint, in case the patient has come for the recent visit to the hospital, will include details with regards to what are the chief complaints for which the patient has visited your hospital for treatment. And of course, the physical examination, the vital parameters are they are the components of a medical records. Apart from that, the drug orders, the consent forms, the laboratory and the imaging investigation results, the assessment and the care plan are important aspects that are looked into as components of a medical record. I would request the participants to add on in the chat box in case you think there are much more details that will be components of a medical record. Moving on to the purpose of a retrospective chart review. So as I had initially said, the basic definition of a retrospective chart review or the closed medical records review is about going back and checking. You're actually going back and checking on your past practices. You are trying to look back into what has been done with regards to the available documentation which is there as part of your medical records. So there are top things that I have just listed here as the main purpose of carrying out a retrospective chart review. Now, number one purpose of a retrospective chart review, I would say, is review for medical necessities. So there are times when a patient has availed treatment in the hospital and they have probably left the hospital after their IP stay. And the patient is coming back coming back for further course of treatment as an outpatient or as a follow-up. And in that case, the clinician would be interested to know as to what was the intervention that has been done for the patient, and how is it that the patient has responded to the treatment plan that has been included. So that is something, that is one reason why somebody would like to go back and check on their closed medical records. Number two, medical legal aspects. This is something very common. So, with a lot of increase in the awareness for the patients who are availing treatment in our hospitals, and with the increase in the social media platform, and people are curious to know about what is really happening to them. So, there are chances that when the expectations that a patient has after availing treatment in a hospital is not met with, a particular patient might go for medical legal cases. And also, if in case there are road traffic accidents or poisoning or any medical legal issues which happen, and for a specific treatment that a patient is admitting to your hospital. So these are various aspects when somebody would like to go back and review your medical records after a patient has left the organization. Number three is review for coding and billing purposes. So, as you know, it is mandatory that we all arrange the medical records in a chronological order, and we have the ICD codification done for the medical records. So, the reason why a reviewer or a medical record reviewer would go back to the discharge case sheet would be to check on the appropriate coding and whether appropriate billing aspects has also been covered. This could also be for the purpose of insurance in case a patient is if he or she is availing a medical reinvestment or availing an insurance services for the treatment that they have taken in a particular hospital, the insurance company would be interested to come back and review the charts to ensure that appropriate treatment has been done and whether the particular claim for the amount that a patient has asked for can be paid or not. So for that purpose also, we do a retrospective chart review. Apart from that, review for research. So review for research, I would say, is that it is always better. I know that you go with an active case sheet audit in case you want to get an appropriate information with regards to the practice or with regards to a certain compliance to a certain protocol that you have set in. However, in case there is a time constraint or in case there is a resource constraints within your organization and you are trying to go back and check if something was done the way it has to be done, in those cases, a review of the retrospective chart is being carried out. Apart from that, review for medical audit purposes. So medical audit is something that most of our institutions do follow. So with regards to a certain disease condition, we would check if a particular protocol is set forth and whether appropriate interventions or appropriate care plan has been implemented as per the set guidelines, and whether the interventions or the expected outcome for a certain patient is achieved or not. So all these are something which will be discussed in your medical audit, and for that purpose, a retrospective chart review is carried out. Apart from that, retrospective data helps to check for adherence to guidelines or standards of practices. And last but not the least, risk identification is something that it might help organizations with. For example, somebody is trying to analyze their falls within an organization. And that particular in charge, say the quality head of your organization wants to analyze what is the risk of a fall in a certain category of patients in a certain identified area of a hospital. So in that case, what you can do is go back and check if the assessments with regards to the fall risk has been carried out appropriately. So you can go back and check on the admission details with regards to the patients who've been admitted in that particular zone, in that particular time period, and in that particular ward. So by doing this, you can identify if there is a potential risk which is identified in a specific zone. Is there anything that you are missing out on? Is there any particular intervention that you need to carry out? So all those are aspects which will help as part of your retrospective chart review. Risk identification is something that is possible by doing a retrospective chart review. Handover documentation, I would say, is not something that is always a component of your case sheet. It is practiced differently in different organizations. It is sometimes handing over documentation is something which is captured within a particular ward as a separate register or as a separate file which is maintained. But however, if you are meaning about the transfer summaries or inter-unit or inter-departmental transfer documentation, if that is what you meant, yes, that does cover as part of your medical records. Apart from that, yeah, incomplete or improper consent. I think I did mention that the consent forms are one component of a medical charts. So yes, we definitely do check for the completeness and whether appropriate consent has been used for a certain procedure in the hospital. So quick review. So we have seen what a medical retrospective chart review is about. We have seen what are the different components of a medical records. We have seen the purpose of carrying out a retrospective chart review. And now we are seeing the sample size calculation for a medical records chart review. So there are two methods by which you can arrive at your sample size. You can use a formula or you can use a software which is like a Minitab which you can use to calculate the sample size. So I've just tried to give an example here by giving in the formula. So what is important for us to know is that with regards to the retrospective chart review, the population size will be the discharged patients details. That is, the discharge case sheets will be the general population size. And from that, how much are you choosing in for your review is what is going to be your sample size. So it is important for us to know that in a retrospective chart review, the population size will be your discharge cases and your sample size will be a portion of your population size that you are going to choose as a sample for carrying out the review. So the main difference, I would just say, in terms of your concurrent chart review and your retrospective chart review is that in your concurrent chart review, the number of total number of admissions will be your population size, whereas your total number of discharges will be your population size with regards to your retrospective chart review. So here I'm just going to give you an example of how you can calculate the sample size using a formula. So basically, you need to define the population size, which is represented by a capital N. Example, if your population size is 1,000 and you are trying to calculate the sample size for 1,000 of your population size, the way you find out is the formula which is used is correction factor into your population size divided by correction fraction plus your population size minus 1. So the correction factor is something which is constant, which is already defined. So this is something that you can use for your calculations. It's a fixed component. So 384.16 is your correction factor. So here, for example, 1,000 is your population size. So the way you will calculate your small n, which is your sample size, will be 384.16 into your defined population size, which is 1,000, divided by 384.16 plus again your defined population size 1,000 minus 1. So that is going to approximately total up to 278. So your 278 will be your approximate sample size with regards to your defined population size of 1,000. That is the sample that you will have to select when you are carrying out your records review. So I have just tried to list out the procedure that you follow in terms of using a Minitab. So the way you calculate your sample size for a retrospective chart review, one thing that we all need to remember is that we need to define your population. So that is the most important thing. And apart from that, you need to calculate, you need to do a pilot study for your retrospective chart reviews. So the sample size calculation, again, remember that we need to define the population, that is with a minimum of 30 case sheets is what you will be including. And what is important is try to include different specialities within the hospital. So if you are having cardiology, nephrology, pulmonology, pediatrics, urology, make sure that you have piloting carried out for each of these specialities. Next will be, the third step will be to calculate the compliance percentage from this pilot study and the proportion level. And after that, you will be using the Minitab software for calculating the sample size. So the first step is defining your population, that is defining the total number of discharges for a retrospective data. Number 2 is calculating your pilot study, that is a minimum of 30 sample size has to be carried out. Number 3 is that calculate the compliance percentage with regards to the pilot study that you have carried out. By means of compliance study, what I would say is, depending on your research question, depending on why you are carrying out your retrospective retrospective chart review. Say, for example, you are trying to analyze the compliance with regards to your medication reconciliation. You are trying to find out the compliance with regards to the completion of your consent forms, appropriate consent forms completion. So depending on the purpose of starting your particular retrospective chart review, you need to calculate your compliance percentage from the pilot study. So from your compliance percentage, you will arrive at your proportion level. And after you have your pilot study done, after you have your compliance percentage carried out, you can use your Minitab. So while using a Minitab, I'm just listing out the options that you will have to select. So while using a Minitab, select on the stats or the statistics option. Click on power and sample size option, which will come once you select your statistics. There will be a drop down which opens up to power and sample size. And sample size for estimation has to be selected from your power and sample size option. So in that, you will have to be choosing your proportion. You will have to be entering the proportion. By proportion, what we mean is the compliance that you have arrived at after carrying out a pilot study. And margin error is something that can be fixed, whether it could be in terms of 0.05, it could be 0.01, or it could be 0.10. It is something that you define on based on your pilot study carried out. And finally, you will have to click on the OK button after you enter the particular sample size, after you enter the proportion and the sample size estimate. So I am just giving you an example in terms of how this is carried out using a Minitab. So first, conduct your pilot study for 30 records from different specialties that you have in your hospital. And for example, you have a compliance percentage of 80% during your pilot study. The proportion will have to be converted as a ratio, so it will be 0.80. And the margin error is something that you can select, say 0.01 or 0.05 or 0.10. And in case you are selecting 0.05 as your margin error, once you enter the proportion with regards to the compliance percentage and the margin error, and once you click on the OK button, the sample size that you would actually get will be 298. So that will be the sample that you will have to be carrying out with regards to your retrospective chart review. So retrospective chart review, I hope the example that I have given is clear with regards to the calculation using a formula and using the Minitab. So now we have seen how is it that we arrive at a sample size by using a formula method and also by using a Minitab option. So once you define your sample, once you define your sample size, you will move on to the sampling method. So one thing that is often carried out by a lot of hospitals, including the hospital where I have worked in the previous couple of years back, is convenience sampling. So what is meant by convenience sampling is that it is basically a non-probability sampling method where samples are taken from a certain group of people only because it is easy to contact them or easy to reach out to them. And it is probably because it is based on the convenience of the person who's collecting the data. So this is a non-probability sampling method. So I would suggest that in case there are organizations or as quality persons or as research students, you are looking at convenience sampling, kindly try and change it. Try to go ahead with a stratified random sampling or a systemic random sampling method. So that it is more inclusive and it is more useful when you're actually projecting a particular data with regards to a certain population. Because when you are looking at the convenience sampling, what you are projecting would probably not cater to the actual data which is expected. So you cannot make a certain decision. You cannot come at a certain inference while you're carrying out a convenient sampling method in your organization for doing your work. For while carrying out a review method. So I would suggest, in case that there are people who've been practicing the convenient sampling, try and work on the random sampling methods or the probability sampling method, I would suggest. So in this particular slide, in this particular example that we are just going to see in the next couple of slides, it will majorly be about what stratified random sampling is about and how it can be carried out and how a systemic random sampling can be carried out. Okay, defined population should also include death cases and llama cases also along with discharge cases. Yes, Ms. Samira, I would suggest yes, because by discharge cases, you would also by default include the patients who have passed away. So basically, all your retrospective chart review will include all the records which will be going back to your MRD or your medical records department after a patient has completed the treatment within your organization. So that completion of treatment is something where a patient is cured and he gets discharged home normally, or it could be that a patient has passed away and uh, the patient has left. So death cases can also be included. And yeah, patients who have left against medical advices also will be part of your discharge case sheets. Yes. But however, when you are looking at doing a specific study with only regards to the patients who have availed treatment and who have gotten discharged, you can make that exclusion with regards to the death cases and llama cases. That is a call that you need to take while you define your purpose of carrying out a certain records review. But what the best practices is, all the records that reaches the medical records, you can find out as to what has been done. The reason I would say, for example, you are looking at a certain intervention to a certain particular, the way a particular disease condition has been handled with regards to a certain drug which has been given to a patient. So in case a particular set of patient has taken a certain drug, the effect has been good for that patient and the patient got discharged after a cure of the particular disease, well and good. But if there are samples where you are trying to find out deviations, like changes with regards to the same set of variables, with the same set of components, but a particular drug doesn't work for a certain set of group of people and it has resulted in adverse issues for a certain patient, even those will help you to get insights while you're trying to find out. So while you're carrying out a retrospective chart review, you can include your death cases and your llama cases also. Okay, now we can just see, as I said, so convenience sampling is something that people usually carry out with regards to the retrospective chart review because it is easier to get the access to a certain record or a certain group of people or a certain set of specialities that you can actually collect data from. However, it is not an ideal method of carrying out a retrospective chart review. It is better that you carry out a random sampling audit. So basically, the sampling methods to be followed for high quality data will be about dividing the sample into groups. That will be your first step. Second step is to calculate the portion of the sample and the population. That is, you will have to define your sample size. Third thing is use a systematic or a simple random sampling instead of the convenience sampling. So here is an example of the sampling method that we can use. So N stands for, the capital N stands for the population size. For example, 1000 is your population size and the sample size that has been chosen is 100. You have arrived at this 100 based on the formula method or by using a Minitab. Imagine that 1000 is your population size and your sample size that you have arrived at is 100. And from here, stratified sampling means you are dividing this population size of 1000 into different groups. You are stratifying it. You are making subgroups within this broad population. That is called as a stratified sampling. For example, this 1000 population size, I'm splitting it into 500 cases from the Department of Cardiology. 400 cases from the Department of Pulmonology and 100 cases from the Department of Nephrology. That is about stratified sampling. You are dividing it into population, into specific groups or specific strata. So proportion between the sample size and the population is 10%. How did I arrive at this 10%? So basically, I'm just calculating with regards to say 1,000. N is your population size. Sample size is 100. So 1,000 divided by 100 will give you 10. So 10 is the percentage of the proportion between the sample size and the population. So I decide to take 10% of the samples from each specialty. So 10% of the sample size from cardiology cases will be 50, 10% of nephrology cases will be 10, and 10% of pulmonology cases will be 40. So this is the method of arriving at your stratified sampling technique. And moving on, choosing the 10th patient for nephrology. So, for example, you know that you have arrived at the proportion. There is 10% is your proportion. Whereas in your systematic random sampling, the way you would calculate this for cardiology, let's take cardiology for example. You have 500 divided the population that has been identified. So you have 500 cases with you with regards to cardiology, and you have arrived at a sample size of 50. So 500 divided by 50 will be 10. So with regards to the systematic random sampling, what you can do is that every 10th case in the specialty of cardiology, you can choose for your retrospective chart review. Similarly, for your nephrology cases, how is it that I'm saying the 10th patient? 100 is your divided population group. So 100 divided by the 10 will be giving you again the 10. So the 10th patient from the nephrology will be selected as part of your systematic random sampling. Similar method is calculated for the pulmonology specialty also. So this is the way by which we arrive at the sampling method. So I hope it is clear. Stratified sampling is about dividing your overall population into strata, into subgroups. And from that, you calculate the proportion from your population size to the sample size that is arrived. And each of these subgroups carry out this particular proportion for your audit, for your retrospective chart review. And with regards to the random sampling, you choose a certain number, say the nth position, the 10th position, the 5th position, the 6th position, depending on the formula that we have just spoken about. And from that, you can choose the random case sheets in each of these specialties to make sure that the cases have been given a probability. I mean, the cases have been given an opportunity for review in your retrospective chart review. So this method can also be carried out using a Minitab. So with your Minitab, you will have to enter the entire details with regards to the 500 case sheets. And using the formula which is there in the Minitab, using the options available in the Minitab, it will let you know which is the 10th, every 10th file that you will have to be auditing, you will have to be reviewing with regards to each specialties will be given with regards to your Minitab. Okay, so we have looked at what retrospective chart review is. We have looked at sampling methods. We have looked at how we arrive at the sample size, and we are now going to check if the sampling, the sample size that we have arrived at, and the sampling method that we have carried out, whether it is the one that is appropriate. How you would do this with regards to the usage of a statistical tool? I mean, with regards to the usage of a Minitab is something that I have just listed out here. So in your Minitab, you will have to select on statistics. There is an option called as power and sample size. In the power and sample size, there is again a drop down which will come where one proportion has to be entered. In that, you will have to enter the proportion, and also the sample size chosen has to be entered. And the comparison proportion is the proportion compliance from the recent analysis. So basically, the study that you have carried out recently, whatever percentage of compliance that you have come at, whatever proportion that you have arrived at, That is in the previous session I was just talking to you, like when you are doing a pilot study, and if you have seen that there is about 80% of complaints with regards to a certain research question that you have looked into, then your proportion compliance will be 0.80. And the hypothesis proportion will be the average proportion of complaints as per the available data. So in case you have a historical data already, so like today when I finish off my pilot study, my compliance rate looks at 80%. However, in the past, you have gone through, you have a set of data which is already available, and it is not 80%. Say it is about 78% or 79%. That will be your hypothesized proportion. And the acceptable power will be the one that will be calculated once you enter the sample size, once you enter the comparison proportion, and this hypothesized proportion in your Minitab. What is important is that the acceptable power, that is the appropriate data, the sample size that you have chosen and the sampling method that you have chosen is appropriate and acceptable only when the acceptable power is 80% and above. So in case you are looking at the 0.80 compliance proportion, and you are looking at 0.78 or 79 hypothesized proportion, the percentage of acceptable power that will be calculated is only about 6%. In that case, it means that you have either gone wrong with regards to your sample size, or your sampling method has to be re-looked into. So what is important over here is while you're checking the power of the sample, it will help you to find out the root cause in terms of where you have gone wrong while you're carrying out the retrospective chart review. Whether you have gone wrong with regards to your sample size identification, or is it about the sampling method that you have done, or is it any other reason why this particular retrospective chart review is not appropriate, the compliance is not appropriate. So that is the reason why we will have to be carrying out with, the power of sample checking. So then moving on with the limitations with regards to the retrospective chart review. As you know, retrospective, as you know, is more historical data. So you are actually going back and looking into what has been done. So it is not concurrent, or it is not helping you. It is not prospective. It is not helping you to look into something which is going to happen in the future. It is about going back to your past and checking if something has been done the way it has to be done. So there is every chance that you will be missing out on some data. You probably are trying to look out for some data which was never captured or which was never documented in your case sheet. So this is one limitation while you are looking at retrospective chart review and the data with regards to retrospective chart review. For example, I would say that there are organizations, in fact, even I have done it when I had recently joined in this particular company. So we were just trying to go back and check on the complaints with regards to the culture, taking of cultures before starting of high-end antibiotics for a certain patient, for a sepsis case. So we were trying to go back, we were trying to just check on the retrospective data with regards to whether the complaints has happened or not. So while we were trying to check on that, we did find out we had a lot of challenges with regards to it, because the details with regards to the culture taken, with regards to when the antibiotics was administered, with regards to whether the culture was even taken before administering the high-end antibiotic, and whether a diagnosis with regards to sepsis was initially made before starting an antibiotic, all those data were missing. So this, I would say, is a major limitation with regards to your retrospective chart review. So while we were trying to carry out that particular retrospective data, we found it very hard, because initially the details with regards to what we were looking for was not communicated to the user end department, and that were never documented as part of their practices, as their routine practices in the ER. So these are some of the things that you will arrive at, because you will only be able to look at some data whichever is available in your case sheet, and you would be inevitably missing out on important data that you probably want but which is not available. That is the first limitation with regards to your retrospective chart review. The next one would be your bias factor. As I was telling you, most of these retrospective chart reviews, while it is being carried out by a reviewer, is something where they do it using a convenient sampling. It is not something that is done in a very structured manner in many organizations. So there is always a bias factor involved. So people tend to be looking or presenting the data that they want to present, and it is not something that is actually going to be useful for the organization as such. The bias factor is one important thing that is that I would say is the limitation with regards to your retrospective data. So these are the two things that I have just majorly listed with regards to the limitations. However, there are advantages of going through your retrospective chart review because it is cost effective, people say. So because you don't really invest on something, you don't really have a separate manpower that will have to do a review of data or checking of your records while a particular practice is happening. This is something that you can do a later analysis also. So at your convenience, at your ease, at whenever there is appropriate resources at your end, you can carry out. That is one advantage of retrospective chart review. However, there are bias factor and limitation with regards to the data which is going to be available. Okay. With that, I think I've just covered with regards to what a retrospective chart review is. Now, a quick recap is something that we will have. With this, we will be concluding today's session. So I'm just going to quickly have 5 questions listed out. So people who have joined us today, you can just leave your answers in your chat box. What are the 2 major types of chart reviews carried out in a hospital? What are the 2 major chart reviews carried out in a hospital? People, if you can just type it out in your chat box. Concurrent and retrospective. Exactly. Concurrent and retrospective. As I had initially, open and closed charts review is also what it is called as. So basically, your concurrent is what is called as open chart review or your active case sheet audits. All those are your it's a type of chart review. Retrospective is what we just spoke about. It is all your discharge cases that reaches out your MRD. Is whatever review that you're carrying out with regards to that is your retrospective chart review. Yes, active and passive audit is also it's called. Active and closed case sheet audit is also it's called. Okay, we'll move on with the next question. Second question is, which is the best sampling method for retrospective chart review? Is it convenient sampling? The best sampling method for retrospective chart review is convenient sampling. True or false? False, 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 false. Okay. The third question is, a pilot study is to be carried out before calculating the sample size in case of a retrospective study. Is it true or false? A pilot study is to be carried out before calculating the sample size in case of retrospective study. Is it true or false? True. Correct. So generally, what is the sample size that you would take while you're carrying out a pilot study? 30. Okay. The fourth question we will go on to. Okay. For concurrent and retrospective chart review, the population size will be the total number of admissions. True or false? For concurrent and retrospective chart review, the population size will be the total number of admissions. True or false? False. Okay. So what was the major difference that I had spoken about in the beginning? So basically, in your concurrent chart review, the sample size will be your total admissions. And for retrospective, what did I say was your population size? The main difference between your concurrent sample size and your retrospective, exactly. Your discharges, total number of discharges will be your sample size. So it cannot be true. The answer is false. So we'll move on to the last question with regards to your recap. The power value for a sample can be lesser than 80% in case of a records review. Is it true or false? The power value for a sample can be lesser than 80% in case of a records review. False. Correct. So what does it indicate? In case your power value is lesser than 80%, what does it indicate? there is an issue with it has to be 80% and above. Your sampling is wrong, or your sample size is wrong, or your sampling method is wrong. Correct. So that was the quick recap. I would just like to finally add on with regards to some of the practices that we carry out as part of our retrospective chart review. So basically, ours is a greenfield. I would say it's a startup in Chennai, in the organization where I work with. With regards to the number of discharges in the hospital, is slightly lesser than some of the fully functional hospitals which happen in the hospital, in other hospitals. So what we do with regards to the retrospective chart review is that all the discharge case sheets are expected to reach our medical records within 2 days. Say, for example, a patient is discharged on the 9th of November. The discharge case sheets will have to reach our MRD by the maximum by the 11th of November. So within 2 days, it reaches the MRD, the Medical Records Department, and we do have the MRD technicians who are the current reviewers with regards to the closed case sheets audits. So they carry out the review of all the discharge case sheets which come. So the timeline that we have defined for carrying out or completion of our records review of each of these discharge case sheets which reach the MRD are 4 days from the day that they receive the records from the wards. So this is being strictly monitored in terms of on a daily basis. The MRD department actually shares the report with us with regards to the total number of discharges for that particular day and the number of discharge case sheets which have reached the MRD and the number of discharge case sheets which has been completed with regards to the retrospective chart review. 1 minute, I'm just stopping my screen share. So that's what we do. So in our particular organization, since we are a startup, it's only been 2 years since we've been fully functional. So since the number of discharges is also slightly lesser, we try and cover 100% of the discharge case sheets being reviewed in our closed case sheet audits. So what we check in terms of the medical records review is something that probably all of you will also be carrying out. But I thought it will be useful for me to just tell you in brief in terms of what we look at. So basically, number one is we look at whether the chronological order of filing is carried out. And apart from that, whether the consent forms are all, whether it's all been appropriately taken. And we also look at whether the appropriate documentation in terms of the progress notes, in terms of your initial assessments, in terms of your transfer summaries, and in terms of your medication drug charts, your medication reconciliation forms, all those, whether it is carried out or not. So this component is also being checked. Apart from that, in case a particular patient has undergone a certain surgery or a procedure, we look at whether the pre-operative orders are updated, then the pre-operative checklists are updated, surgical safety checklists are done, your operative notes are documented, the post-operative notes are documented, and the records with regards to your implants in case it's used, and the investigation flow chart, the nutritional assessment, and in case the patient is in the ICU, what is the progress notes? Whether the progress notes has been updated on a daily basis or during the stay during the ICU is checked into. The nursing care plan is checked into. The doctor's SOAP notes is being checked into, and the reports of investigations whichever is carried out, that is also being checked, and the patient's education record is looked into. And apart from that, the investigation order sheets are also checked into. And apart from that, the transfer summaries, in case a patient has gone to multiple locations of the hospital or from ICU, to what transfers has happened, and in case a modified early warning score is used for a certain patient, all those are aspects also which are looked into. But something that we importantly look at more in terms of the compliance aspect will be the concerned aspects. So this is something that we do insist on, and we insist that the consent form is taken by the particular member of the procedure team, I mean the surgical team or the surgeon and the anesthetist involved. So how we cross verify with regards to whether this is being happening appropriately or not is that these case sheets before the close records review happens are also being checked for your active case sheet as part of your active case sheet audit. So the person carrying out the active case sheet audit does have the records with regards to whether this was done during the hospital stay or it was incomplete during the time when the patient had undergone a procedure. However, by the time it reached the MRD, it was closed. So even all those are some things that we look into. So I thought I will just quickly give you a recap. I mean, give you an overview in terms of what we do as an institution. The sampling size and the sampling method with regards to our retrospective chart review in our organization is not relevant because we carry out the closed case sheet review for 100% of the discharge cases at present. But in future, as our hospital grows, we will be following the points that we have just currently had a discussion with regards to, say, the sampling size and the sampling methodology that will have to be used will all be carried out accordingly. So I hope I've covered all the aspects with regards to the retrospective chart review and the sampling method. Tenerisu sir, do you want to add on something to my presentation today?
Yes. Thank you, ma'am.
Sir, can I ask one question to the presenter, sir?
Yeah, please go ahead, ma'am, please.
Vidya ma'am, what is the you from your message? I could understand that the closed file record has been done by the medical record team. Am I right, ma'am?
Yes,
the file
yes,
review.
Yes, ma'am. But we do have a clinician involved as part of our review, our medical records review team.
But what about quality department, ma'am? Is there any involvement from quality department?
Yes. During the active case sheet, quality team is involved, sir. And close case sheet audit, we will be having a weekly review with regards to the findings of the close case sheet audit. But active case sheet is being carried out on a daily basis.
Is it multidisciplinary team or just only medical record people?
No, multidisciplinary team is what I said, sir. Sorry. Our clinician will be there, our medical records technician will be there, and a quality personnel will also be there.
What about nursing department?
Sir, our quality department representative is one of the nursing staff, sir.
Okay.
So she will be representing that, sir.
No problem. Yes, Anusha, ma'am, please go ahead.
Yes, sir. Correctly, you pointed my thing. This is actually, if you see even in NABH and JCA, there is actually a requirement that say that we have identified individuals and it is done by a multidisciplinary team. It should have a minimum representations from all stakeholders. So we should definitely have representation from everybody to say it is a multidisciplinary team, which does both open and close. So closed in the sense, the thing is, once the file reaches MRD, so the team has to audit, and then only usually in many hospitals you will be having the closed medical record review team. What they does is they go to MRD, and whichever the MRD technicians identifies and saying deficiency, usually they'll have a habit of putting a sticky notes or somewhere they mark and keep it. But the best practice is the closed medical record review should happen before that has been done, because the purpose will be that the audit is done, it has been identified, and the relevant stakeholders are being put into the process of closure of deficiencies. That is how the process is ideal way should be. If after closing the deficiency, if we carry out the audit, ultimately the finding will be we won't be having any findings. The complaints will be more than 95%, and it is not going to serve the purpose. Even a even an open field audit, it should be a multidisciplinary team, because what we do in our institute is we have a multidisciplinary team. We put a rota in such a way that, because of the rota is ruled from the quality department, we divide the areas and we rotate among ourselves. Maybe once in a month, the area will be changed between quality, nursing, and other things, because always the third eye concept works. Because we go to the single area, we miss the findings, so that we are getting things exposed to all the areas and the findings is. And one more information for the audience also to have it. So once it's been, even though the topic is on the chart review and other things, the exhaust requirements on the contents of the medical records should be developed from the quality cell in consensus with all the stakeholders. Because if you see for NABH or JCA requirements, what we require in documentation is very, very exhaustive. So for example, the forms which is listed in the presentation is just an overview. If I say a consent form, or if I say, even if you see consent form, one example, everybody will be aware on the parameters like risk, benefits, alternatives, or complications, or whatever we call it. But if you see even in requirements, it also talks on your success rate. It also talks on your likelihood of success. And there are almost 9 parameters which is requirement on a completion of consent forms from JCA's point of view. So from quality professionals or whomever is going to prepare an exhaustive checklist, they have to pick each and every element or objective elements or measurable elements which is required from the NABH and JCA. It has to be pinpointed against each and every form, so that everybody goes into the audit is very clear on what is required in each of the medical records, because medical records differ from hospital to hospital. So I will say this is a message for whomever in the group to have and think when we prepare an audit checklist for a medical record review.
Thank you, ma'am.
Thank you, sir.
Yes, Vidya ma'am, thanks a lot. So
Thank
clear
you.
content, and even there is some exercise in Minitab. And I have some questions.
Yes, sir.
So
Yeah, I'm just going through.
sample size and sampling method is not appropriate in your organization, correct? Because the total number of discharges is very low, correct?
Correct, sir.
So what is your current total number of discharges per quarter? And Vidya ma'am, is there any timeline for retrospective review, whether we need to do daily or just only once per month or quarterly once? Is there any timeline for medical record review?
Sir, we do it on a daily basis, sir. That's what I was telling you. So basically, the discharge case sheets which come in to our hospital, to our medical records, on a daily basis, it is being checked. And as Anusha ma'am was just talking about it, checklist is defined by getting inputs from the necessary department heads, by the necessary the concerned stakeholders, and that is how we have prepared the checklist. Like ma'am was telling, owing to the time constraints and owing to the fact that I cannot include all the specific details with regards to the components of a record, the checklist that we have defined with regards to what we review as part
actually,
of your closed case.
But actually, there is some standard checklist for medical record review.
Yes, sir. Actually, if you see, it is actually an organization policy, but the minimum requirement is we have to take samples at least from the quarter period of the samples, sir. Quarter period of patients. For example, in a quarter, if I have this many admissions and this many discharges, from that I can take a representative population and then we can go ahead. This is a JCA requirement which is there in the MOH.
Yeah, even for JCA, no need to review or record daily. We can. This is like a patient experience survey. We can do at least once per quarter. So why we need to waste our time? Correct. Even if there is resource, if there is manpower, we can concentrate, we can focus on other things, correct? So why we need to spend more time for medical record review? So I think quarterly once. What is your total number of discharges per quarter, ma'am?
Sir, recently we have increased, so it is about 900 to 950, sir, for a quarter.
Per quarter.
Discharges.
So even for this scenario, we can use sample size. We can calculate sample size, and for me, no need to review daily, ma'am. For medical record
I understand, sir, but sure, sir. I'll take this forward with our concerned heads, and we will just have a discussion on that. More so because initially the flow was very less, so the organization was looking at making sure that the appropriate records are reviewed. Every record is reviewed is what they had done initially. So that is still continuing now. But as the cases
ma'am, actually simply we can check each and every record for normal things. But for medical record review, there is some standard checklist. There is some standard methodology. And even we need to use the sample size and everything. So this we cannot do simply checking each and every file, whether the physician signature is available, whether notes is available. So this is not a normal checkup, correct? So there is some special methodology for medical record review.
Correct.
So, and what about the next one? Even now we can use EMR, correct? For medical record, now we can use electronic medical record system,
Yes,
or
sir.
health information system.
Yes,
But
sir.
what do you think? If it is electronic form, is it possible to collect data from each and every record? Is it possible to assess each and every record? Because now everything's electronic. There is no more paper. So what do you think? What is your advice? Is it possible to review each and every record?
Sir,
Because of the electronic system.
Yes, sir. Today we were having a discussion in one of our meetings, sir. We are in the process of moving towards electronic medical record from next month onwards.
Okay.
So with regards to, once we have electronic medical records in place, some of these aspects with regards to the mandatory things which have to be filled in, I think it will all be taken care. And in terms of what are the statutory requirements, and in terms of what are the requirements which you will have to fill in, will all be available and will all have to be inputted in your EMR. So in that case, it is going to make things simpler for the review processor. And yes, I do agree. In that case, once EMR is in place, we will not be able to carry out the audit for every aspect, sir.
Okay. Is there any significant gap in the current practice regarding medical record review? What do you think, as per your practice? Is there any significant gap in our current review, especially for medical record review?
I mean, generally, you are saying, sir,
yeah, generally,
I was
not from your practice. Generally, is there any significant gap in our current practice regarding medical record review? Whether people aware about this practice, because as per JCA standard, the compliance of medical record documentation is very important, correct? This is not only for standard, even for our patient satisfaction, for better treatment, for quality of our treatment, documentation's compliance is very important. But what about our quality professional, and what about our physician nurses? Whether people are aware about this importance of documentation? Is there any gap in the current practice?
Sir, honestly, I should in fact agree here in this forum that quite a few things I had learned while preparing for today's session, sir. Like, for example, I was talking to you about the sample size selection. So, I mean, we are so much used to the routine that is carried out during our workplace. I mean, at our workplace, that we end up thinking that is the right way of doing it. But then what statistics and standards say is something that we should actually, all of us, have to look into. So that awareness aspect is something that I think we all have to update ourselves with regards to that. And yes, there are chances that the bias factor is something that does play a role when you are trying to do a retrospective chart review, because there are some people who still use the convenient sampling method and not really a structured random sampling technique. So those things, I would say that we still have to update ourselves towards the right practices.
Exactly. And yes, ma'am.
Sir, I would like.
Yes, Anusha, ma'am, please.
Yes, sir, I would like to add something on the electronic medical record review part, sir. So even though actually we say that many organization has an electronic medical record in OPs, mostly in OPs. IPs actually, as far as concerned in India, it is very less in for IPEMRs.
Okay.
So certain things like the completion of documentation, maybe the prescription and capital letters, is it the time and SNDT is complete, that the time and things, those things we can take it for granted it is done, sir. When we do an electronic medical record review, so there are we also should be, quality professionals should be involved in the process of development also. So it should not allow for a simple things, because if we keep a mandatory field, they may just enter a space and then they will move on to the next one. So that is also possible in one case. And the next one is, it is a requirement when we have an electronic medical record from the JCA that the organization has a mechanism to monitor the cut, copy, paste function, sir. So requirement is like, it is very easy because we also do cut, copy, paste from Googles and everywhere into any of the presentations, whatever we do, it is very common. And doctors has a habit, even for discharge summary, they will be having some template of summary and they copy paste into a medical record of another patient. So there is always a possibility of high chance of error, and it is the responsibility of the IT team or whatever you call it as an HIS team, or however you call in your organization. They should say that how many times the cut copy function has been enabled and how many times the concerned person using the electronic medical record has acknowledged or accepted it and edited. So when I cut, copy, paste into a system, the system should have a provision to say that it is going to give me an alarm or pop-up, or it should be in a different color font or different style font, maybe a bold or italic, so that the person reviews and accept that this is required for this patient and proceed. This is a one part we have it as a requirement when we have an electronic medical record in any of the institution. For the review purpose, this will be answered from the IT back then, not from the completion of documents from the quality or medical record perspective, but IT is responsible to answer this question when it is a JCA audit.
Exactly. Thank you, ma'am. And Vidya ma'am.
Yes, sir.
Is there any standard from any BH for medical record review, especially for medical record review? If you need more accuracy, if you want to know the exact percentage of complaints, and if you want to know the root cause regarding medical record complaint, is there any specific standard from any bit standard?
Yes, sir. It is mentioned as part of the key performance indicator annexure, sir. The screening population and the sample size is mentioned. But I remember, sir, in one of your sessions, you had spoken about how these are probably not the ones which are statistically approved. Probably
Yes. Hypothetical.
And
quota sampling.
hypothetical. Yeah. So quota sampling is what you had mentioned.
Yes.
During one of our classes, I think, sir. So, in fact, it was an eye-opener for me only after attending your session that day, because as I told you, we are so much used to working towards an accreditation or a certain routine that has been fixed within our organization. And we just stick by whatever is told in that. And sometimes we are not thinking beyond that.
Yes.
So I think it is important we look beyond what is mentioned and look at what is the best practices to be followed.
Yes, ma'am. Thank you. And one more last question, please. Just a minute, Anusha, ma'am. Just a minute. Last question. And if we calculate power with the help of Minitab, if we calculate power, actually, if you're going to calculate sample size and sampling method, if you choose optimal sample size and if you use appropriate sampling method, then why we need to calculate power?
Sir, you are actually including data with regards to what was available. The historical data with regards to the complaints is also we are including in that power calculation, sir. So that will actually give us.
So if you got less than 80%, so if you got less than 80%, what are things we need to assess? The sample size and sampling method, also the content, correct? What are the items available in the checklist, correct?
Yes.
The assessment tool, is there any mistake in the assessment tool? Not only sample size and sampling method, even we need to check the tool. Is there any mistake in the tool? Tool means like checklist, correct?
Yes, sir. Yes, sir.
So this is also one of the contributing factor for low power. Not only sample size and the sampling method, even the content. Excellent. So this is also we can use, actually power we can use to validate our outcome. Suppose if you got, sometime we can show in front of any of which people like the percentage of complaints regarding closed medical record review, 98%. We can show just to get certificate from any of which, correct? But after calculating percentage of complaints, we need to calculate the power also. Is it more appropriate? Is there any bias in the outcome? So with the help of power calculations, we can validate our outcome, not only for data. Actually, in statistics, we can validate our data before analysis. Also, we can validate our outcome after analysis. Is it appropriate? So is there any bias in the outcome? Yes. So this is also good. Thank you. Thank you, ma'am. So a lot of new things, learning for new lessons.
Sir, once again, I would like to place my gratitude here, sir, because quite a few things I learned while preparing for this particular session. I have to thank you, sir. Thank you so much for the opportunity.
Thank you, ma'am. Excellent PPT, and hopefully we'll convert this as research paper. We'll publish as a research
Sure,
paper, because still many people are not aware about this kind of practice. So we'll publish as a research paper.
Sure, sir. And thank you everyone for the patient listening. And I must say it was slightly interactive too. I had a lot of chats.
Any question from others, please? Just we have 2-3 minutes for others, please. Any questions from others?
Hello, sir.
Yes, sir, Dr. Reshma, ma'am, please.
Yeah. Thank you, Dr. Vidya. It was an excellent session. And yeah, all our points are refreshed, and it's good to know that we are going beyond NABH. And we are trying to, because if the mindset of our quality managers are changing and moving towards data analytics, that is actually the way forward. So all the best to you on behalf of this entire group. Thank you.
It was moving towards customer satisfaction, not for JCA certificate or any business.
Correct. Yeah.
Yes.
Yeah.
Thank you, ma'am. Thank you.
Thank you. All the best.
Thank you, ma'am. Any other questions from others? Any appreciation from others to Vidya ma'am, please?
I would say that overall it was nice to take it from the scratch, because for whomever is attending, this is a very new one, how to select, because even though NABH book says that you have to take samples based on the statistical principle, everyone will run away when we hear the term statistics.
Yes.
So to stand, so if somebody, we get an assessor very strong and saying that how do you have selected samples, we may not have a right answer to say them until unless we know the answer for this terminology. So I think for those who are not practicing this, this will be a real opener. Those who are already into it, this will be a representation, as somebody told before me.
Any other question, Anusha ma'am? I'm sorry. Any other questions, Anusha ma'am? Anything
No, sir. No, sir.
Share?
No, sir. No, sir.
Okay. Thank you. Thank you, ma'am.
Thank you, sir. Thank you, sir.
Others, please. Any questions?
All good, sir. The session is great. It was a refresher again for the last session we had done for the medical record review, especially the sample size and all.
So whether you got any new things from this session, sir?
I got to understand something about the discussion for the power of sample.
Yes.
Earlier we had done about the sample size along with the the sampling methodology. So this was a good addition, gave more information and strength to the discussion.
Thank you, sir.
You're welcome, sir.
Thank you all.
Thank you, sir. Good night.
You all
Thank you and good night.
Thank you all. Good night.